Coming up next on Being Well, Dr. Chip Rowe, orthopedic surgeon from Paris Community Hospital, will be here to talk about arthritis. We'll learn more about what causes arthritis and what effect it has on the joints. Dr. Rowe will also share some advice for things you can do today to prevent arthritis and manage it if you already have it. There's a lot of great information coming your way, so stay right here for Being Well. Well, I'm so happy to be joined by Dr. Chip Rowe, our orthopedic surgeon from Paris Community Hospital. Today we're talking about arthritis. How many people do you estimate in the U.S. are afflicted by arthritis? Do we have any idea?
Millions. If anybody lives long enough, they are at risk for developing arthritis. With the baby boomers and their levels of activity, arthritis is having an impact, not necessarily because there's more arthritis, but because they want to maintain a higher level of activity as they get older, and that does have an impact on their lifestyle and quality of life.
Okay, well, why don't you explain for us what exactly is arthritis? And you have some models here. Tell us what's kind of going on if you have arthritis.
Arthritis, strictly speaking, refers to inflammation in a joint. The most common cause of inflammation of a joint is cumulative wear and tear in the joint. If we were to look at the end of the bone, this happens to be a model of a knee. If we were to look at the end of the thigh bone or the top of the shin bone, it would appear very white and shiny and smooth. What gives it that appearance is a carpet of cartilage, which is actually our built-in anti-friction device. It actually is the slipperiest surface known to man. Arthritis, plain and simple, is just the wearing out of that carpet of cartilage.
Okay.
The most common type of arthritis is what we call degenerative arthritis or wear and tear arthritis, or technically speaking, what we call osteoarthritis. That's the most common variety. Other types of arthritis, probably the next most common, are what we call inflammatory arthritis. That's your rheumatoid, your lupus, your psoriatic. Same underlying principle. The cartilage is hastened along in the process of deterioration by our own body attacking the cartilage. Fortunately, that's not as common as wear and tear arthritis. Oftentimes, if we look at the common form of arthritis, it has been initiated by some sort of traumatic event at a younger age. An injury where you tore one of the supporting structures, a ligament, or tearing one of the bushings or shock absorbers in the knee that we call the meniscus, which, you know, when people refer to having a torn piece of cartilage in the knee, most often they're referring to a torn meniscus as opposed to damage to the joint surface.
So there's some pretty good chances if you were a student athlete in high school, played football, basketball, had some injuries, you probably are going to see some arthritis later in life.
There definitely is that correlation and expectation. I can speak from experience.
So let's talk about are there certain populations that are at higher risk for arthritis?
Yes and no. Kind of going back to the beginning, congenital things that we were born with. We can't change the genes that we were born in. Some people have better quality cartilage than other people. Those people may have a tendency to see wear and tear in their 40s and 50s or early 60s as opposed to, you know, the 70 or 80-year-old. There's also other factors, somebody who has knocked knees, bow legs, subtle changes in the alignment of their hips, certainly may be more susceptible. So there are those factors that we are born with. And then the other factors we've already talked a little bit about injury, a traumatic event, either sports or an auto accident or something. Then there are other things. Probably one of the greatest contributors that is not mentioned often to development of arthritis is cigarette smoking.
Really? And why is that?
Well, because cigarette smoking affects the oxygen carrying ability of all the cells in our body, and the ability to withstand wear and tear in cartilage is undermined by the effects of cigarette smoking. Not kind of a special form of arthritis is the wearing out of the discs in our back. People have herniated discs or degenerative disc disease. The incidence of disc herniation is about 20-fold greater in a smoker as opposed to a non-smoker. And so there's a lot of these things that, you know, when we think of smoking, we think of lung cancer, but cigarette smoking is so pervasive in terms of the effects on the body that it is unimaginable. So smoking, diabetes has an effect because of impaired healing, and also lends itself to being overweight. So people who are obese on the real heavy side, it's kind of a fallacy that activity lends itself to arthritis. You know, you'll have people say, well, don't go out and run too much because you'll cause arthritis. In effect, that's a fallacy, because unless you have contributing factors, obesity or knock knees or bow legs or malalignment, the activity is actually beneficial to the cartilage because it helps it withstand or hold on to the water that it uses as kind of a shock absorber and cushion. So appropriate, consistent activity is probably the single most beneficial thing that I know in terms of moderating the effects of arthritis.
Okay. It affects the joints. Are there certain joints that are more prone to arthritis than others?
No question. Most common is the knee joints, and interestingly, it's far more common in women than it is in men. The incidence of arthritis in the knee joint is about 4 or 5 to 1 in women compared to men. The hip joint, it also is a little bit greater, but typically the weight-bearing joints. Interestingly, though, you would think if that was truly the case that the ankle would be the most common, yet the ankle is relatively spared except for people who have a specific injury or have one of the inflammatory arthritises. The elbow tends to be relatively spared, and again, even the shoulder does, but the shoulder, probably number one is the knee, and then the hips, and then the shoulders.
Okay. Well, we've been, the basic, the one that people are probably the most familiar with is the osteoarthritis.
Yes.
So what are some of the symptoms of that?
The symptoms of osteoarthritis most typically are discomfort, often described as aching, toothache type pain, particularly after activity. Because the joint is not perfectly smooth, it causes irritation. The body's response to that irritation is inflammation. So after you finish an activity, oftentimes the knee or the hip or the shoulder, and it can include the hands. I neglected to mention the hands. It's very common. We tend to do less for the hands than we do for some of the other joints, but typically aching and swelling are kind of the hallmarks of osteoarthritis as a function of activity, either doing too much or not doing enough.
Okay.
Because activity actually does help pump the fluid out. It generates more lubricating fluid and kind of keeps the surfaces smooth, so that if you're not active, kind of the analogy that I use is if you have a nut on a bolt and it hasn't been used for a long time, it takes a bigger wrench to get it moving.
Right.
Whereas
It's a little rusty.
if every day you came and just moved that nut a couple of turns both directions, even though it may still ultimately get corroded, it's still going to continue to move, and you're going to be able to do it with your fingers. Whereas, you know, you wait a month or a year or several years, then you got,
wrench out.
and then you strip it, and then you got bigger problems. So again, back to the premise that the single most beneficial thing is consistent, appropriate activity.
So if you're someone like me and you have kind of that occasional ache or pain like in my hip after I run, it's not terrible. What sort of things can I do just to sort of alleviate some of that and make it a little bit better for myself?
The important things are warming up properly. Don't go out with the idea of testing yourself.
Don't leave the house running at full speed.
Being consistent with your activity. And if you do get symptoms, one of the first measures that can be taken is just icing it. One of the simple things I suggest to people is just get some Dixie cups and put them in your freezer full of water. When you finish an activity where you've got some discomfort or some aching, just grab one of the Dixie cups and tear the top down an inch or so and massage that area that hurts. The other thing that is commonly used in this country are medications, which we dump into a category called non-steroidal anti-inflammatories. The original was aspirin. Now you've got several other ones that are available over the counter. I'm not a big proponent of taking medications all the time. I suggest that they be used as a tool. And in being used that way, they are actually most effective if you take them before the activity.
Okay.
And so what I tell people is if you know you're going to go out and go on a shopping spree or you're going to go bird watching and, you know, walk further distances, take, you know, 2 or 3 Aleve or 3 or 4 Advil with some food before you go do the activity. If despite that you get a little bit of increased achiness or pain, then take it consistently for 2 or 3 days to get things quieted back down to your baseline. It's not to say that there's not a situation where some people have to take them all the time, but again, you have to weigh the benefits versus the risks, and you know, they do have side effects.
Right. So you could probably live with that for a while. At what point, you know, if you have osteoarthritis, does it get so bad that you would recommend someone see their healthcare professional?
Well, when it impacts your sleeping, because they can ache at night, it can hurt at night. If you're starting to get what I call mechanical symptoms, you can't fully bend or straighten the knee or the hip, or you're getting sensation of catching or popping or locking, which suggests that there may be some other factors contributing to the aggravation of the arthritis, or when you start compromising what you want to be able to do. And in that setting, there are some adjuncts that I or any orthopedic surgeon or, you know, other specialists who are comfortable dealing with it can use as adjuncts, such as injections into the joint, either with additional lubricating fluid or with cortisone. Both of those can help moderate the symptoms and enable a person to continue a higher level of activity for a period of time.
Okay. Let's move on to, we've talked about osteoarthritis, but there's a lot of other arthritis.
Absolutely.
There's rheumatoid arthritis. Can you explain, what is really the difference between osteoarthritis and the other types?
Osteoarthritis is what we lump into the category of wear and tear arthritis. That is, there is not a true cause and effect of something abnormal or deficient in the body that is contributing to it. In reality, as we learn more, there probably are some chemical processes that do evolve and that is a little bit different in everybody that's contributing to wear and tear arthritis. But again, it's kind of like the tires on your car. You know, you put enough miles on them, they're going to wear out. The category of inflammatory arthritis falls into a category where we can identify a specific cause that has the effect of causing inflammation and destruction in the joint. In rheumatoid arthritis, we can actually find a congestion of white blood cells in the lining of the joints, which are releasing chemicals that actually actively destroy the cartilage itself. Same thing with psoriatic arthritis. There is an abnormality of the body that has as collateral damage the destruction of the cartilage. Same thing with gouty arthritis. It's the accumulation of uric acid crystals in the joint elicits an abnormal response, which has as collateral damage the destruction of the cartilage cells. So most often in that situation, the effort is directed at trying to eliminate or moderate that specific process that is causing the damage.
So are there causes of things like rheumatoid arthritis, psoriatic arthritis, or is it just something that you can just unfortunately get?
It's not entirely clear. There certainly is an element that's passed along from within families, but there are equally those that occur sporadically where there really is no family history. There are a lot of theories. Is it exposure to environmental toxins? Is it triggered by a virus? Nobody really has an answer for that.
So those are the types of arthritis that you see that children can be affected by?
Most definitely. Juvenile rheumatoid arthritis, I'm not aware of psoriatic in children. It's more common to first kind of rear its head in your 20s or 30s. There are some of the other childhood arthritises, what we call spondyloarthritis, which are the result of, again, probably abnormal genetics, which makes a person more susceptible. But juvenile rheumatoid arthritis tends to be a fairly aggressive form of rheumatoid and certainly can have devastating consequences.
And can you actually have several forms of arthritis?
No question you can. That's always disputed. I mean, most often we try to find one thing that explains everything, but there's certainly no question that you see people who clearly have features of both osteoarthritis and rheumatoid arthritis or osteoarthritis and gout or lupus. There's a variation of gout which is called pseudo-gout, same process but different crystal in the joints that precipitate things. So it is possible to have more than one type of arthritis.
Do you want to talk about, there's of course always new medications and treatments. What sort of new things are on the horizon or out there for people who suffer from things like RA and diseases like that?
Well, there's new things even with degenerative, which is more common, looking at some of the underlying chemical mechanisms and trying to improve the lubrication. But yes, probably the greatest impact we've seen with the inflammatory arthritis, the tried and true method for moderating the process of rheumatoid and lupus and psoriatic has been cortisone or prednisone. They are very effective but have significant side effects. More recently there have evolved a class of what we call biologic modifiers, which truly change how the white blood cells function. Humira, Imbral, there are even some newer ones which are in affect what are called the mitochondria in the cells. And interesting, there seems to be a lot of overlap between the moderation of how those cells behave, and so you now see Imbral being prescribed for patients with psoriasis. Mickelson, the golfer, he's
when someone famous has a disease, it always seems to bring that up.
Molecular biology and cellular biology is making great strides towards impacting the severity of symptoms with rheumatoid arthritis. I have a 24-year-old daughter who was diagnosed 2 years ago with rheumatoid arthritis, and she started off with prednisone and methotrexate and gold and did terribly, and they started her on Humira, and she does incredibly well on Humira. So to me, because I saw the consequences of prednisone and the devastation of long-term rheumatoid, to see her doing so well, at least early on, is a relief to me.
At what point does surgery become an option?
Surgery becomes an option when the symptoms of arthritis reach a point where they're truly compromising the quality of a person's life. And the way I explain it to people is when you get to the point where day in and day out you're not doing the things that you want to be able to do, and there are things that you're not willing to give up, that's when I believe the potential benefits outweigh the risks. And fortunately, we have intermediate term experience, especially with knee replacements, which there's approaching 1 million a year done in this country alone. Hip replacements, which there are now probably about 500,000 done a year in this country, and shoulder replacements. So we have about 30, 40-year, 50-year experience with those. Fortunately, they are excellent options in terms of relieving the symptoms and significantly improving or restoring the function. So it really boils down to a quality of life issue. When you've exhausted other measures, and as they say, your quality of life is so compromised, then there's a trade-off. You can't keep your heart and your lungs healthy. You can't keep your weight down if you can't continue to be active. So you have to factor that into it as well.
Okay. I want to, as we wrap up here, I want to run through a couple of quick questions. Someone had asked this on our staff. It's an old myth of cracking your knuckles. Does that cause arthritis?
It does not. That's just air bubbles or nitrogen gas bubbles popping in the joint.
Okay, we got that answered. Okay, what types of exercise, if you have osteoarthritis and you're a little stiff and sore, can you recommend, what's a really good type of activity to do?
It depends upon the severity. Probably the easiest, kind of in the mild to moderate stages, is just getting out and walking. Good pair of shoes, relatively level surfaces. Again, we're a biologic system. Our body will adapt to a consistent stimulus. So if you get out and walk consistently 3 or 4 days a week, you'll find that your symptoms will actually get better. As you get into kind of the moderate to more severe, then you want to limit the load or the weight bearing on the joint. So that I'm a big proponent of cycling, either a stationary bike. It puts the lower extremities through a gentle, full range of motion. You get significant repetition. The other thing that is tremendous is swimming.
Sure.
The other thing that I use is a rowing machine. because it's non-impact loading, and I can, impact both my upper body and lower body.
So as we wrap up here, just give us a couple of things that we can do now, lifestyle changes that can either maybe not prevent arthritis, but can, maybe lessen the effects of it.
When I see patients who I'm dealing with arthritis, it's become, almost rote, the spiel, and I hate to call it a spiel, but what I tell them is we don't have a way to cure the arthritis, that is, put new cartilage in there. Therefore, our initial treatment is to provide them with the tools to moderate their symptoms to allow them to be as active and as productive for as long as possible. Number one, activity modification, where you can avoid squatting, kneeling, heavy lifting. You're not doing any harm, but no point in hurting. Single most beneficial thing is consistent, appropriate exercise. Walking, swimming, cycling, rowing. Third thing is weight management. Definitely don't let your weight go up, but for every pound that you can lose, that amounts to about 5 pounds of decreased load across your joint per step.
Oh, wow.
So someone who walks 1,000 steps a day, who loses 5 pounds, 5 times 5 times 1,000, 25,000 pounds of force that you can decrease across the knee joint on a daily basis just by losing 5 pounds. It's huge.
Very significant.
Fourth thing is not being afraid to use a walking stick.
Okay.
I call it a walking stick because I had a woman in San Diego get up and walk out on me because I suggested that she use a cane. And that was too embarrassing to her, and so I now call it a walking stick, and there's a website called Canes R Us. You can find a cane that will fold up in every purse, will match every outfit. It's pretty cute. I had a patient who came in that did that. So using a walking stick, and you use it in the hand opposite the side that hurts, which seems backwards, but if you practice it, it becomes natural. You can shift your weight away from the side that hurts. The fifth thing is the appropriate use of medications. You can start off with Tylenol, but that really doesn't help with the inflammation, but then Aleve or Advil. And then the final thing is, go see your physician and talk to them about the options for injections, braces, and other alternatives for exercise.
Okay, and don't smoke either.
Don't smoke. That goes without saying.
All right, well, Dr. Rowe, we are out of time. Thank you so much for coming on Being Well and sharing some great information that I know our viewers will benefit from.
I hope they find it helpful.
Thanks. Don't forget, you can watch full episodes and demonstration segments from the Being Well series. Visit us at youtube.com/WEIU TV.